Hello everyone. Now I'll be discussing question of oncology. So we have a 9-year-old boy brought to the emergency with seizures in the school, and he fell on the ground and sustained flexion of the arm and extension of the legs. The child has been tired and irritable lately, and school performance has declined. Frequent headaches are there, and there is decreased muscle strength in the left side of the body. Brisk deep renal reflexes in the left arm and leg. Visual field of examination is normal. Okay. MRI of the brain reveals a space occupying lesion in the right parietal lobe. Which tumor is most likely in this patient? Well, the answer is polycystic astrocytoma. But before I discuss this question, let me tell you some basic concept about pediatric brain tumors. We broadly classify into supratentorial or infratentorial. This is the boundary line that you can see. So when we talk about supratentorial, we are talking about tumor of the pineal gland, astrocytoma, optic gliomas. Okay. And when we talk about infratentorial, then we talk about medulloblastoma, cerebellar astrocytoma, infratentorial ependymoma, brainstem glioma. Craniopharyngioma is a type of supratentorial. It's in the supratentorial. Okay. So this is a broadly classification, supra and infratentorial tumors. Now, in the pediatric population, like in our patient, the patient is of 9-year-old boy. Serious tumors are the most common solid tumors. Point to be noted. They are second most common after leukemias. But do not forget, leukemia are liquid tumors. This we are talking about solid tumors. So second most common is CNS tumor. Most common solid tumor is again CNS. Low-grade astrocytoma, particularly polycystic astrocytoma, is the most common brain tumor in children. And of course, presentation depends on at what site this tumor are present. As I told you that supratentorial tumor, they classically come with headache. Weakness, sensory changes can be there. Posterior tumor, which are usually infratentorial, they are usually with cerebellum dysfunction. They come with ataxia due to involvement of cerebellum and dysmetria. Of course, headache can be there. There are signs of increased intracranial pressure whenever brain tumor is there. Early morning headache and vomiting. It's a classical feature that we see in a case of brain tumor. Papilledema, this is again due to raised ICP. They can occur in the tumor enlarges regardless of tumor location, whatever, maybe in the supra or infratentorial. Whatever we have increased intracranial pressure, then can lead to type of, we get feature of raised ICP. Okay. Well, most low-grade astrocytoma cause symptom due to local pressure on the adjacent structure because they are benign tumor. They grow slowly. They do not undergo malignant transformation. The patient right parietal mass is most likely due to be astrocytoma, as I told you, the most common tumor type of brain cancer in the pediatric age group. Now, can we think about other option, craniopharyngioma? It's arising in the sella turcica, as I told you, is a type of supratentorial. And it appears as cystic structure with calcification. On imaging, symptoms include visual field defect, hormonal deficiencies. Well, now you can stop the video, write down the answer. Which hormone can be deficient in this type of patient? Quickly write down, stop the video. The answer is growth hormone deficiency can occur. Okay. Well, visual field defect we are getting in this patient. Now I have one more question. Stop the video, write down the answer. Visual field defect we get in pituitary tumor also. Visual field defect we get in craniopharyngioma. CP is short form of craniopharyngioma. Okay. Now write down the answer. What is the difference in the field defect? Okay. Well, I give you a clue at least. In both these conditions, there is bitemporal hemianopia. Hemianopia. Now the question is, what is the difference between the two? Quickly write down, stop the video. Well, this is the optic chiasma. Okay, let me say. And we also know that the pituitary tumor arises from below. And as far as optic chiasma, it arises from the top. So it will compress from up. It will compress from down. Pituitary tumor, this pituitary. This is craniopharyngioma. So in optic chiasma, in pituitary tumor, pressure comes from below. That's why upper field is lost. Vision of upper field is lost. And craniopharyngioma is pressing from up to is lower field vision is lost, although both are bitemporal hemianopia. Well, there's a classical picture. You can see beautiful picture of craniopharyngioma. Let's look into other option. Ependyoma, they are glial cell tumors. They arise from the ependymal lining of the ventricle and the spinal cord. We are well aware the inner lining of the ventricle, this cavity is ependymal cell. And in children, the most common site is the fourth ventricle in the posterior fossa. So definitely when it is arising in the posterior fossa lining, it is going to have obstruction of CSF flow, and that lead to increased intracranial pressure, and it can also lead to hydrocephalus. Why? Because it is causing obstruction to CSF flow. Weakness and seizure are less common with ependymoma because they are arising inside the lining of the CSF flow site, right? Well, I have a simple question for you. Stop the video, write down the answer. We can get hydrocephalus also in maybe some bleeding in the meningeals and somewhere in the meningeal bleeding, which could be epidural, subdural or subarachnoid hemorrhage. Now question is, out of the three sites, extradural, subdural or subarachnoid hemorrhage, this hydrocephalus is most likely to happen in which of the three conditions, extradural, subdural or subarachnoid hemorrhage? Well, stop the video, write down the answer. The answer is subarachnoid hemorrhage. There can be hydrocephalus can be a complication. Well, let's look into other option. We have one option is medulloblastoma, is the second most common tumor of the posterior fossa in children. Well, this is infantorial arising from cerebral vermis. It presents with vomiting, headache and ataxia. Well, I have one more question for you. Stop the video, write down the answer. So we learned about so many tumors so far. Now, brain tumor, normally they do not go outside the CNS, outside the brain to be more precise. But out of all these, there is only one tumor which goes out or where metastasis can occur. Which brain? Primary brain tumor, of course. Primary brain tumor can have metastasis, extracranial metastasis. Stop the video, write down the answer. Answer is medulloblastoma. Is the only primary brain tumor which can have metastasis. Well, when we talk about neuroblastoma, it arises from sympathetic ganglion cells. They may present as abdominal mass. Metastasis may occur in bone and liver also. But in the late stages, they may go to brain also. Okay. Well, but as I told you, primary brain tumor are much more as compared to secondary. Just to inform you, in adults, secondary brain tumor are much more as compared to primary. This point should be very, very clear in your mind. Children, primary more common in adults, secondary more common in brain tumor. So, golden line to remember, CNS tumor are the most common type of pediatric solid tumor. If they ask cancer, then leukemia. Solid tumor is brain cancer, and astrocytoma is the most common type of primary brain tumor in children. Just a brief word. Manifestation of tumor of location supratentorial, increase intracranial pressure. Posterior fossa, increase intracranial pressure, ataxia and clumsiness. Brainstem ataxia, clumsiness, cranial nerve palsy. Spinal cord tumor, back pain. Weakness, abnormal gait. They are the features, summary, golden line to remember for the brain tumors, location wise. Thank you very much.